Nutrition is a process of providing or obtaining the food necessary for health and growth. Today, we'll be looking at all you need to know on nutrition for the NCLEX. We'll start with infant nutrition. Let's start with premature infants. These are births that occur before the 37th week of pregnancy. They are usually less than 2,500 grams and less than 37 weeks of gestation. Their nutritional requirements is usually between 100 and 200 calories per kg per day, and they have higher sodium, calcium, and protein requirements than full-term infants. Usually their body composition is more of water, less protein and fat per pound than full-term infants. They have poor temperature control due to the little subcutaneous fat. So you can see if you compare a premature infant with a full-term infant, you could see there's a marked difference. The premature infant's bones are poorly calcified. They also have poor sucking reflexes. Their gastrointestinal and renal functions are poor, and they are very prone to infection. There's also immature development of their lungs. Our plan and implementation for these infants would include parenteral nutrition. This would involve intravenous administration of nutrition, and this is usually required until oral feedings can be established. We could also use gavage feedings, where a feeding tube or a gavage tube is used to give nutrition to infants who cannot eat on their own yet, usually because of poor sucking coordination. So we could use gavage feedings. Again, you also want to use soft nipples. They are very effective for very small infants. In terms of supplements, vitamin A, vitamin C, vitamin D, and iron are usually given orally. Occasionally, vitamin E is needed to prevent oxidation of the red blood cells. Glucose is often substituted for lactose in premature formulas because of its passive absorption in the GI tract. And also vitamin K prophylaxis is given to prevent clotting problem. So that's our feeding tube, especially used when the infant cannot eat on their own or due to poor sucking reflex. If we look at full-term infants, this is a baby born between 37 weeks and 42 weeks. They are considered term. Nowadays, pregnancy is considered term at 39 weeks, but generally these are infants who weigh between 2,500 grams and they are greater than 37 weeks of gestation. Usually they have high energy requirements. Their rooting and sucking reflexes are well developed. The rooting reflex helps the baby get ready to suck. You can check for that when the roof of the baby's mouth is touched. The baby will try to or start to suck. That's your sucking reflex. Rooting and sucking reflex, okay? So these infants, full-term infants, should at least produce 6 to 8 wet diapers per day and at least 1 stool daily. In terms of breastfeeding of the full-term infant, human milk is ideal. It's recommended for the first 6 to 12 months of life. And we know initially colostrum is secreted at first. Colostrum is clear, it is colorless, it contains protective antibodies. It is also high in protein and minerals. Subsequently, milk is then secreted after day 2 to day 4. Milk has the milky white appearance, and it contains more fats and lactose than colostrum. We'll also consider formula feeding in full-term infants. Formula is cow's milk that's modified to resemble human milk more closely. So you want to avoid cow's milk in the first year because it's deficient in vitamins and iron. It's usually diluted to reduce the protein content. Sugar is added to increase the carbohydrate content. And formula is necessary for the first 12 months of life. Then unmodified cow's milk is then acceptable. So if there are problems with diarrhea, you'll need to change the formula to prevent profound dehydration. Your feeding technique, while you're feeding the infant, you want to cradle the child when he's being fed, and the client should be the regulator of the milk volume. In terms of introduction to solid food, you want to introduce only one food at a time for each week, each 2-week period. So only one food at a time for 2 weeks. Again, the least allergenic foods that could cause allergy, the least ones are given in the first half of the first year. Then more allergenic foods could be added. Example, the eggs, orange juice. These are offered in the last half of the first year. So the usual order would be cereals, fruits, vegetables, then one can progress to potatoes, and then meat, and then egg, and then orange juice. Please, no honey should be given during the first year due to the high risk of botulism. That's a very good NCLEX question. Remember, botulinum toxin blocks nerve impulses, causes muscle weakness and hypotonia. So you can see this infant with botulism. You can see it causes muscle weakness and poor muscle tone, hypotonia. So the infant would have trouble breathing and would require mechanical ventilation. For toddlers, these are kids between the ages of 1 and 3, or 12 to 36 months of age. You will notice 6 to 8 teeth have erupted and they begin to use large muscles and bones. So you want to allow choice of food from the food pyramid to prevent struggle over eating, because the child may prefer one food or one type of food over another. So these are food pyramid. So you want to have more of the food come from the lower part of the pyramid, and you can see our options. We have bread, cereals, potatoes, and we want to give like up to 4 servings. And then we can progress to fruits and vegetables, and we can give 2 to 4 servings. And then we can progress to milk, cheese, and dairy, and then meat, fish, and the least we want to offer would be fats and oil, confectionery. So these should be used sparingly or occasionally. It should be offered to the toddler occasionally. So we know that the toddler needs fewer calories in diet, but more protein and calcium than the infant. And you want to give 32 ounces or less of formula to decrease risks of iron deficiency anemia. For the adults and the elderly population, what are their nutritional requirements? We already know that with increased age, there's reduction in calories that's needed in the adult and in the elderly. There's also or balanced diet continues to be important. We know that there's calorie limitation with decreasing physical activities. The elderly become less active, and as a result, their calorie requirements also decreases. Again, in the elderly, there's a declining ability to chew. And there's also changing taste perception, and this can also cause impaired nutrition in the elderly. So the goal is to decrease calories, but you want to ensure that the food consumed is high in minerals and vitamins. You want to prevent osteoporosis, especially in the elderly postmenopausal women. Again, you want to reduce all-cause mortality. You want older adults consuming oral protein and energy supplements. Let's look at enteral nutrition. Enteral nutrition generally refers to any method of feeding that uses the GI tract to deliver part or all of a person's caloric requirement. It can include a normal oral diet, the use of liquid supplements, and all of that. So what conditions require enteral feeding? So one condition that would require enteral feeding would be preoperative need for nutritional support. So the client who is scheduled for surgery, he might need increased nutritional support, especially if there's inadequate intake preoperatively that results in poor nutritional state. So we might want to use enteral feeding to increase his or improve on his nutritional state. Again, gastrointestinal problems that could be as a result of fistula or short bowel syndrome. Or short bowel syndrome is a malabsorption disorder that is caused by a lack of functional small intestine. So that could also cause, it could be a reason why we want to use enteral feeding. The client could also have Crohn's disease, which could cause these gastrointestinal problems that will require enteral feeding. Crohn's disease is an inflammatory bowel disease, which causes inflammation of the digestive tract. We know it can lead to abdominal pain, severe diarrhea, fatigue, weight loss, and malnutrition. Again, ulcerative colitis, which is a condition that also results in inflammation and ulcers of the colon and the rectum. Your primary symptoms for a client who has ulcerative colitis will be the abdominal pain, and you notice that there's blood mixed with diarrhea. There's also weight loss, fever, and anemia. Another condition that will require enteral feeding would be if a client is undergoing radiation and chemotherapy. So that adverse effect of this oncology therapy would require us to carry out enteral feeding. Again, chronic illnesses could cause alcoholism, psychiatric or neurological disorders can also result in chronic depression, eating disorders, and we'll need to carry out or institute enteral feeding in our clients. Again, head and neck disorders or surgery could also be a requirement for enteral feeding. So that's our short-term enteral nutrition, and you can see the tube through the nose into the stomach. So this would be our nasogastric tube, and if it continues into the intestine, the jejunum, it will be our nasojejunal tube. This is delivered through the nostril and then the esophagus to the stomach or intestine. And this is a short-term use or short-term enteral nutrition, while this would be our long-term enteral nutrition, and is delivered directly to the stomach or intestine through the abdomen. So we'll have that opening that connects to the stomach from the abdomen. So this would be called our gastrotomy tube. And if it opens up into the jejunum, it will be our jejustomy tube. Okay, so what are complications of enteral feeding? One, you can have mechanical tube displacement. For this, we'll need to replace the tube. There could also be aspiration. So to avoid this or to prevent this, we need to elevate the head of the bed. And you always want to check residual before a new feeding. So that residual, what do we mean by residual? Residual refers to the volume of fluid remaining in the stomach at a point in time during enteral nutrition feeding. So the nurse will withdraw this fluid via the feeding tube. You connect your syringe and pull back on the plunger. It's usually like a 60 ml syringe. And you do this at intervals ranging from 4 to 8 hours. Again, you still need to push back all of those fluids because after the measurement, you want to push it back into the patient's stomach to prevent fluid electrolytes, and nutrient loss. So if the gastric residual is more than 100 mils, you want to delay the feeding. You can also wait 30 to 60 minutes and do the residual check again. If the residual continues to be high, then feeding cannot be given. You need to notify the healthcare provider. Another complication could be cramping, vomiting, diarrhea. Probably the feeding rate is too high. You want to decrease that. Again, you might want to change the formula to a more isotonic solution, and again, administer at room temperature. Again, we could also have metabolic hyperglycemia. So you want to monitor the glucose level, give insulin if needed, check your serum osmolality. Again, if the rate is running at a very fast rate, you need to reduce that. That could cause your metabolic hyperglycemia. Dehydration is another complication of enteral feeding. For this, we can flush the tube with water according to hospital policy. And again, we could have formula drug interactions. So before you mix formula with your drugs, you want to check compatibility. Again, you can also flush the tube before you give the medication and also flush it after you give the medication. Let's look at parenteral nutrition. So this will be feeding of nutritional products to a person through his IV intravenously. So you are bypassing the usual process of eating and digestion. Remember, enteral nutrition went directly into the stomach or the intestines, but parenteral nutrition goes straight into the IV. So what are the methods of administration of this parenteral nutrition? We could give it peripherally. So this is used to supplement oral intake. And you should not administer dextrose concentrations above 10% because it's going to cause irritation of the vessel walls. So this is our peripheral parenteral nutrition. Another option or another method of administration is through a central line or through a central catheter that's inserted into the subclavian vein. So this would be our subclavian vein here. This is our subclavian vein. We have what we call peripheral inserted catheter, or the PIC catheter, or PIC. Is threaded through a central vein. We can give dextrose solutions above 10% into this line, probably into the basalic. So this is our basalic vein, or it could also be given through a cephalic vein, and then straight to the superior vena cava. And it can stay for up to 4 weeks. There's also the percutaneous central catheter that will also go through the subclavian vein. Then we also have the triple lumen catheter or triple lumen central catheter. So this would be a triple lumen central catheter. It has a distal lumen. So this would be our distal lumen of 16 gauge. So we can use this to infuse or draw blood samples. The middle gauge is actually 18 gauge. The middle lumen is 18 gauge and it's used for parenteral nutrition or parenteral nutrition infusion. And then the proximal lumen is also 18 gauged and is used to infuse or draw blood and administer medications. So again, the 16 gauge, you can use it to draw blood or infuse blood, while this would be, middle gauge would be for parenteral nutrition infusion, and the proximal would be for infusing medications or drawing blood. There's also the atrial line. So we have our atrial catheters like your Hickman, Biovac, Groshong, and also we have the subcutaneous ports here. So this is an example of our subcutaneous port. So a rubber needle is used to access this port through the skin. And then you connect through these ports and you can give your parenteral nutrition. So again, the initial rate of parenteral nutrition infusion should be between at least 50 mils per hour initially. and gradually increase to 100 to 125 mL per hour as the client's fluid and electrolyte tolerance permits. So you want to infuse the solution by pump. You also always want to use a pump at a constant rate, because this will help to prevent abrupt change in the infusion rate, because increased rates results in hyperosmolar states. And what will you notice in your client? He will have headaches, he will have nausea, he will have fever, he will have chills and malaise. And again, if the rate is too slow, this will result in rebound hypoglycemia, which is caused by the delayed pancreatic reaction to the change in insulin requirements. Again, you don't want to discontinue suddenly. You don't want to discontinue your parenteral nutrition suddenly. Also, you want to change your IV tubing and filter every 24 hours. This is a good NCLEX question. Change your IV tubing and filter every 24 hours. Again, you want to keep the solutions refrigerated until it's needed. And when it's needed, you want to allow to warm to room temperature before use. If new solution that you want to connect is unavailable, then use 10% dextrose and water solution until the new solution becomes available. Monitor daily weight, glucose, temperatures, intake and output at least 3 times a week. Check the BUN, electrolytes like your calcium and magnesium. Check your CBC, your platelets, thrombin time, liver function studies like your AST and ALT. You also want to check prealbumin levels, serum albumin once a week. Do not increase the flow rate if your PN is behind scheduled administration time. Don't try to rush it and feel like you are lagging behind. No, do not increase the flow rate. In terms of discontinuation, you want to gradually taper the infusion to allow the client to adjust to the decreased levels of glucose. After it's discontinued, isotonic glucose solution is administered to prevent rebound hypoglycemia. Remember, we said in rebound hypoglycemia, you would see weakness, fainting, diaphoresis, shakiness, confusion, tachycardia. So those are signs you will see in rebound hypoglycemia. So what are complications of our parenteral nutrition? There could be infection or sepsis. So you want to maintain a close intravenous system and also use your filters. This will prevent germs from passing through. No blood should be drawn or medications given through the parenteral nutrition line. So if you're using a triple lumen, you use the right one for the right procedure. Again, apply a dry, sterile, occlusive dressing to the sites. We could also have another complication, which could be pneumothorax because of the line placement. So your parenteral nutrition should only be started after chest X-ray validates correct placement. If you need to do your chest X-ray to confirm our PN tube is where it should be. Again, monitor breath sounds for presence of shortness of breath. You want to monitor that because of possible pneumothorax complication. So monitor his breath sounds and also check for presence of shortness of breath. We could also have hyperglycemia, for which you want to monitor glucose level and serum osmolality. We could also have hyperosmolar coma. So this could also be referred to as hyperosmolar hyperglycemic syndrome, or your HHS. Could also be referred to as non-ketotic hyperglycemic syndrome. It's characterized by severe hyperglycemia, hyperosmolality, and dehydration in the absence of significant ketoacidosis. Remember, hyperosmolarity is a condition in which the blood has a high concentration of salt or sodium, it has a high concentration of glucose and other substances, and as a result, this draws water out of the body's other organs, including the brain. So we could also have hypoglycemia. For this, you want to hang 10% dextrose solution if the parenteral nutrition is discontinued suddenly. If it discontinues suddenly, the client can go into rebound hypoglycemia. So you want to put up 10% dextrose solution. You could also have fluid overload. So you want to monitor breath sounds. That will tell you if there's fluid overload, especially fluid backing up in the lungs. Again, monitor his weight and peripheral perfusion. Do not try to rush your PN infusion. You could also have air embolism. So check your clients for respiratory distress. And when you want to change your tube or the cap, you want to change the tube or the cap, avoid the, you should carry out the Valsalva maneuver. Hold his belt or bear down during tubing and cap changes. This will help to avoid air embolism. In consideration of nutrition during pregnancy and lactation, we know that individual needs varies, and recommended weight gain is usually 24 to 28 pounds. During this period, folic acid is needed to prevent neural tube defects and megaloblastic and macrocytic anemia. So in terms of assessment for the nutritional requirement during pregnancy and lactation, we want to assess the pre-pregnancy weight. We want to confirm and assess the maternal age. We want to carry out hemoglobin and hematocrit tests. And again, we want to know if there are pre-existing health condition. So again, remember, folic acid, if this defect, the spinal bifida, could result as a result of poor use or unavailability of folic acid during the pregnancy period. So in terms of diet and plan for pregnancy and lactation, we need to also consider high-risk pregnancies. So which are high-risk pregnancies? The adolescence period is a high risk to pregnancy because they have their own nutritional requirements for high protein and calcium, and there's a tendency to deliver low birth weight babies. So we classify the adolescent as a high risk pregnancy. Again, clients who are diabetics are at high risk, so we want to monitor their glucose level closely, prevent post-mature deliveries, and C-section may be necessary because the mother may not be able to handle the glucose requirements of labor. A client with sickle cell is also a high-risk pregnancy because the stress of labor and pregnancy must be considered in relation to the oxygenation capabilities of these mothers. C-section is usually indicated. Clients with also cardiac conditions, we know that there's myocardial stress specifically related to delivery. And this would require decreased activity as well as C-section to decrease demand on the heart.